what I wanted to do is I wanted to talk about how the quality of the pharmacotherapy for first episode patients has long-lasting effects. And just to use an example of two individuals, uh, both of whom developed a psychosis while they were in college. Both of them were very promising. Ellen Sachs was a student at Vanderbilt. Nathaniel Ayres was a very promising musician at Juilliard. They had two very different experiences with treatment. Uh, Nathaniel Ayres was treated with excessive doses of antipsychotic. He disengaged with treatment, and he hasn't really engaged in treatment since. Ellen Sachs, because of the has continued to engage in treatment, and her life has flourished. She won a MacArthur Award. She's a chaired professor at USC, and really an inspiration for many patients and their families. Uh, and I think that many of these profound differences, I think, could be traced to what happened when these people were first engaged with treatment. Um, I think that as first episode treatments are disseminated around California, I think there are important principles of treatment, of pharmacotherapy treatment. First is that, the usual principle when someone comes in, we have to understand their illness before we treat them, leading to very long delays. People with psychosis need to be treated, and they need to be treated despite often diagnostic uncertainty. Uh, Treatment should not be delayed. I think Bob Heinsohn's slide about the difference in outcomes based on people who had a prolonged period, I think the average time was something like 74 months, uh, that had a profound effect. We need to be concerned about the physical health of our first episode patients. We make decisions early on that have long-term consequences on their physical health because people with psychotic illnesses die too young, and they die from cardiovascular disease by and large. The other thing is we should be optimistic because people with first episodes have high response rates. They should do very well. They respond to much lower doses of antipsychotics. Bob Heinsohn referred to the Port guidelines. They suggest that people with first episode be treated at the very low end of the diagnostic range for antipsychotics, and yet when people in the RAISE trial looked at what people were receiving, most of them were not being treated within that range. Moreover, they're highly sensitive to side effects. When early on in my career, I worked with a colleague who some of you know, Ted Van Putten, and we found that the most important predictor of whether an individual would do well on an antipsychotic could be determined by talking to them a few hours after they received their first dose. If they felt miserable, they were unlikely to stay on that drug and to continue on treatment. So clinicians need to be highly sensitive to side effects. The vulnerability of first episode patients to side effects, I think, was best displayed in an NIMH study reported by Lynn Sikich from North Carolina, in which people were 8 to 19 years old. They were assigned to 3 different antipsychotics at the usual dose range, and all of the patients did well. They had the usual high response rate. But then when you look at their weight, this was an 8-week trial, and these are individuals. And you could see that people who received antipsychotics associated with weight gain, olanzapine and risperidone, in 8 weeks experienced profound changes in their weight. If you look at the number of people who had a 10% weight gain in 8 weeks, you could see it was probably nearly half of the subjects who received olanzapine, leading to changes. And if you look at their metabolic changes, the people who received olanzapine, the blue bars, you could see that they had elevations in cholesterol, LDL, triglycerides, all indicating that they were developing insulin resistance. Which I think leads to my final slide, is that as these treatments are implemented, patients need to be monitored. And I think quality of care for first episode requires that clinicians who treat these psychosis be well monitor their weight. These are some of the guidelines. The Mount Sinai guidelines came from a process that I ran. The other guidelines followed after that based on the Mount Sinai guidelines, but they include that clinics that implement first episode treatment should be able to monitor glucose, weight, lipids, and that's part and parcel, I think, of quality treatment. Okay. Just the summary of my point is that the quality of the initial treatment can have long-lasting effects on both physical and mental health, so we should do it very carefully. Thank you very much.
So I'm just going to talk briefly a bit about the community academic partnership that we've developed in the Bay Area. And I see lots of prep folks here, so hi. So just a little background, I was a graduate student at UCLA and very familiar with Dr. Nuechterlein's long-standing program for first episode patients. University setting, high fidelity to evidence-based practices. Really, he'll tell you some outstanding results for patients. And I moved up to UCSF and said, great, I'm doing research with first episode patients. I will refer them to the local first episode clinic. And I looked around and no one knew what I was talking about. So that's a perspective I started from. And I'm going to talk a bit about how it works to actually move those evidence-based practices into community settings. And I think that's a real challenge for all of us to be thinking about. So this is an example. So the PrEP Collaborative, this is the first county in San Francisco that we were involved in. I want to highlight that there's a number of different partners. So PrEP is some folks at UCSF, some people at FSA, now Felton Institute. Sorry, I don't have your right logo. Also Mental Health Association in San Francisco, and in our other counties, other groups, Mental Health Association of Alameda County, Sojourner Truth Foster Care Family Agency, which was focusing on foster care youth in a certain sector of the city, and then, of course, the county partners. So they're complicated little animals. So this is just an example for you of some of the differences, because we are the Wild West here in California, and every county enjoys having their own unique program. So it's slightly different in each county, exactly who's seen, but mostly the same. So first episode, and in one county we also see high-risk clients at risk for psychosis, similar age ranges, although you'll see some differences. One interesting thing about the Mental Health Services Act is that it has been interpreted slightly differently in different counties about who is served. So in some counties, it is all residents of the county. In some counties, it is those who are on various kinds of public insurance, Medi-Cal or other varieties. So it really depends, and you can see that in the description. What do we do? Well, we decided to take, at the time, which was 2008, every evidence-based practice for first episode psychosis and put them all together. So I don't recommend anyone do that, but we tried. And so it involves approaches around care management, individual cognitive behavioral therapy for psychosis, and I have a few details on that for you. The kinds of medication management that Dr. Marder just spoke about, psychoeducational multifamily groups. I know there's some other counties in California doing that work too. The supported employment and education work that Dr. Nuechterlein will talk about, using peers and family advocates, support and skills groups, and sort of substance use treatment integrated throughout. As you all know, that's a critical piece. So everyone gets some variety of these elements depending on their needs and their interests. This is a snapshot of who we've seen. This is from the second half of 2014, where across the 5 counties, we saw over 300 clients and their families. Some of those are individuals who may have only been with us for evaluation. As you all know, it's a difficult early diagnosis to make. We get lots of referrals, and part of our job is to try to evaluate people and get them to the right treatment. So sometimes we're not the right treatment, but we do an in-depth evaluation and then try to do a very warm and supported handoff to the right places. And that's actually very useful in and of itself, even if they don't turn out to be eligible for these programs, which is a new approach in community mental health. Usually, as many of you know, you go, if you live in a certain region and you are a certain age and you have Medi-Cal, then you go to this community mental health clinic. The idea that we have requirements around, well, what are your symptoms like? What's your age? Other elements, it's new. It takes a little while for communities to adapt to that idea. Now, we are not a research trial. This is just program evaluation. There is no control group for the scientists in the room. You'll hear lots of information. You heard about RAISE. You'll hear, there's a difference. So I want to make sure everyone understands that. It's a little bit about what we're seeing and what you in your programs would be evaluating, because you will not be able to say from the results of what you're doing that in comparison to something, you're better. What you can say is a bit about describing what you're doing. Something like EpiNet or EpiCal may be able to use different ways of pulling that data together to ask some interesting questions. So we do see reductions from baseline to a year later in symptoms, a variety of them, different kinds of symptoms associated with psychosis, depression, which is a really important target in this population. I think we all know how high the rates are of suicide attempts and completions, unfortunately. We do see a reduction in emergency room visits from if you look at the year prior to coming into the program and the first year in the program. Interestingly, we don't see a statistically significant difference in hospitalizations, and one of the challenges there is how you are actually able to measure that. It's something the outcomes group might talk about, but this is a highly mobile young adult population. They often move around, they are off at school, come back, they may have private insurance sometimes, and then Medi-Cal other times, and tracking down the information to find out how many days they were actually hospitalized in all these different places is very complicated. There may be some data technology-oriented solutions to this. We do see an improvement in how many people are employed, and I don't have the education graph. We don't see them at the levels you will hear Dr. Nuechterlein talk about. And I think what happens there is that one of the challenges to implementation, these are small teams, and each person on the team is critical. So when there is turnover of your supported employment person, suddenly no one's getting supported employment. And it's something that, as a state, I would like us to think about. How can we support each other? In some way, there's this sort of idea of a hub and spoke model. They've done this in other places, for example, in Florida around their version of CPS, Child Protective Services, different teams where you can find a way to support each other during these transitions and perhaps help each other with training, because these are intensive evidence-based practices. You can't hire someone and next week they're doing the work. There's a lot of training involved. So I think I'll show you a bit how turnover can be a challenge in these settings. High rates of service satisfaction from our clients, so that's good. So cognitive behavioral therapy for psychosis, I won't show you the slides because I promised I would keep my time short about how effective it is in schizophrenia generally. You'll have to trust me on that one. What we do is look at how it can be implemented. So developed a training. This is all done by Dr. Kate Hardy, who's now at Stanford. And there's a 16-hour workshop that is both didactic and experiential, role plays, feedback and practicing, and then weekly consultation. Therapy sessions are audio taped and then rated on a fidelity scale by Dr. Hardy and then later by people she trained to do that. And competence, not fidelity, but competence. It's not how often are they doing the intervention, but are they doing it well, is defined for us as submitting 3 tapes in a row that are at 50%. It's pretty low, actually, 50% adherence on the fidelity scale, but 3 in a row at that rate. And then people submit tapes every 3 months after that to show they're maintaining competence. So here's a little bit about what that looks like. So we have larger numbers now, but for this slide, we had trained 39 clinicians in a 4-year period, and by offering the training kind of every 9 months or so to the various clinicians in the different counties. Here's the good news. Average number of tapes it took to reach competence, 6. Really not bad, pretty good. Average number of weeks, 56. So what happens? People don't submit tapes, right? In the real world, we're doing some of these sessions, many of them outside of the clinic, trying to get busy clinicians to focus on that piece, not the easiest. Of those 15 who achieved competence, everyone maintained it who didn't leave the service. More of them left than stayed. Of those who were in the process of achieving competence, that's the 8 that were still in process when we put this data together. And then 16 of the 40 left before they even reached competence. So very high rates of turnover. And that, I think, is one of our biggest challenges around implementing evidence-based practices. It's not specific to early psychosis at all, but when you're thinking about some of these practices, you have to think about how it will fit for your organization. There is no answer to the question, which elements should I use? We don't have comparative effectiveness studies for this kind of work when it comes to implementing a whole program in the community. So just to know that, you're going to hear examples, and I think it has to do with thinking about what are your resources, and as long as you adhere to the coordinated specialty care model elements, that's what's most important. Then there are other kinds of debates about whether you use specific evidence-based practice or not that we can't fully answer for you at this time. Maybe NIH needs some comparative effectiveness studies to take a look at that, or to use EpiNet in some way. But that's not where we are quite right now. So that is a description of all the folks that we have partnered with. There are a lot of them. Many of you are in the room. Thank you very much for that.
So the Cognitive Assessment and Risk Evaluation Program, we have actually had this in place for 15 years, and it's been a research program for 15 years with individuals in the prodromal phase of illness as well as the first episode. So the research program began in 1999 when I received some NIMH grant funding to start a program looking at risk factors for the development of psychotic illness. And throughout the years, we have done a tremendous amount of community outreach and education. We've gotten to know everybody in the San Diego County, I think, all the schools, all the community clinics, all the primary care physicians, pediatrics and adult. So in this process, we have worked with lots of prodromal and first episode patients. And after many years, I realized that we really needed to start implementing a lot of the things we were learning in the research realm. And so that was part of the reason we decided to start a treatment program. We always, as part of the research program, one of the ways we kept recruitment coming into our research program was by doing really extensive evaluations, consultation. We'd give feedback to all the clinicians in the community. We wanted people to keep sending them to us, and so we became the experts in the area that could give them information about how might you treat this individual differently. And over again, I'd go to NAMI, I'd speak to different advocacy groups, and patients would come up to me and say, "Are you taking patients? You know, where can we get cognitive behavioral therapy, and where can we get these things that you're telling us that we should be getting for our children?" And I had a hard time finding that. We do have a county program in San Diego, but we were getting a lot of insured patients. We were getting UC employee children and doctors' kids, and they were trying to find services. And so I said, well, let's just do it. And at the same time, the University of California in San Diego was our psychiatry department was under pressure by the dean of our medical school to really develop a better clinical service. We've always been known for our research, and we have a lot of research dollars, but if somebody needed to find a psychiatrist, they couldn't really find one. So we were told, you better get your act together. So I saw a window of opportunity. We had a few specialty programs, and I said, I'm going to start a first episode specialty program. And you know, of course, our department, they're trying to kind of get their act together, and they said, well, you need to come up with a business plan. And I kind of go, well, how do I do that? You know, I got a copy of someone else's, and we plugged our numbers in, and I consulted with a few business people I knew, and I gave them our business plan, and they said, okay, go with it. And we were in the process of changing chairs, and I thought, okay, well, I've got a budget. I can, or a little budget fund I can set up, and I just started seeing patients, hired a few people, and while nobody was watching, we had started generating a lot of income, and so now I've just continued to add. So again, the focus of our work is early identification, trying to target the illness effectively and prevent early psychosis. I always show this slide that shows the brains of individuals who have a first episode of psychosis in the middle here. And it shows the increased loss of gray matter compared to a normal population in this first 5 years of illness. And I always show this because I think that it represents a window of opportunity of what we can do in this phase of illness. And a lot of the focus of the research programs I've been involved in have been how can we predict illness, how do we understand the mechanism of illness, and then how do we intervene effectively. And I think most people here are probably familiar with some of the clinical high-risk studies in which we're able to predict probably about 30% of individuals who will convert to psychosis. I'm part of a national consortium of 9 sites across the country that is looking at predictors of later psychosis, and we've identified a number of risk factors, including a number of things like neuropsychological domains and family history, and specifically which symptoms we rate on the SIP scale are more predictive. So hopefully within the next few months, we will have a paper come out in the American Journal in which we'll look at predictors of psychosis and the development of a risk calculator based on some of these things. And I won't go through it because of time, but we've been able to identify a number of factors that could be plugged in and identify who's at greatest risk. Because especially in the prodromal area, you want to be careful about what types of interventions you use. And don't necessarily want to jump to antipsychotic treatments, given all the things that Steve was saying. So we want to figure out who's at highest risk and who do we want to be the most aggressive in intervening with. We also study a bunch of biomarkers. Again, these may eventually go into the equation. And my interest in this is not only on how you can predict illness, understand the mechanism, but how might you also personalize it based on the mechanism that you identify. And I'd like to see some of these develop so that they are easy bedside tests that can be used in the clinic. They aren't something that you have to have a fancy electrophysiology lab to be able to use, but you could do something simple. And again, we've been working on things like blood tests that might give us indices of who will later develop a psychotic illness based on inflammatory and oxidative stress measures or looking at morning cortisol. We have a number of different NIMH-supported studies going on that are looking at some of these therapies like cognitive behavioral social skills training, compensatory cognitive training, and then biomarkers. So, and we also have a bunch of pilot studies. So having this clinic, we're able to introduce things like one of the residents in our clinic is doing a mindfulness trial. We're also looking at neurofeedback and metabolic parameters as predictors of later psychosis. It turns out that that prodromal subjects have metabolic abnormalities before they even start an antipsychotic. So that in itself. So in terms of developing our treatment program, I think that I don't need to go through the statistics of just how frequent first episode psychosis is. And so we developed our program in order to address these needs. And we have also developed an intensive outpatient program that has been very successful, where we have a 3-day-a-week program, 5 hours a day, where we implement, again, all the evidence-based treatments. I looked at everything across the country that was doing this kind of work, looked at clinics, how they staffed them, how they funded them, how many FTEs they had, what kinds of treatments they were providing, just to get an idea of how I might set this up. Again, we've already heard about CBT. Luckily, I have people in San Diego. We have a lot of great experts in psychosocial treatments. I tapped into Eric Granholm, who's developed a cognitive behavioral social skills training model, and he's helped train all of our clinicians, both for the study we're doing, but also for the treatment that we provide in the clinic. He does lots of outreach in the community and trains people on how to use this. So we've implemented his design. Cognitive remediation, again, I think most people know about a lot of the work that's being done in this area, a lot of it with computerized type programs. But we have Elizabeth Twomley at San Diego, and she's developed a compensatory cognitive training paradigm. And this is, again, a study that we're doing, but we are also implementing it as a treatment within our clinic. And it's a manualized, very common sense approach. And it looks like we've just, we're going to be able to set up a whole cognitive training type of lab for young people where we'll be able to implement some of this. I'm always interested in things like exercise interventions, and this is another thing we'd like to see done. So again, this just summarizes a bit of the kinds of things we include. And it's interesting. It's been an interesting process dealing with private insurance. We've had to get lots of single case agreements to get people to agree to pay for these services. We have to get approval. So we've had to set up a whole, it's one thing when you're dealing with county services, but with private insurance, you have to be nimble to be able to deal with every permutation that they have. So that's been a real challenge. And we have a nice group of people. We've about doubled it at this point. And this is just our program. So thanks.
We actually started at UCLA, a first episode clinic, already in 1980. And given the comments earlier from Cam, I'm surprised I'm still able to walk up to the podium. Much of our research in the early years was not treatment-oriented research, it was more basic research. I'm going to focus on the last 15 years of research that's been randomized controlled trials and show you some successful treatments for first episode schizophrenia. I'd like to acknowledge that most of this research was NIMH funded, and Bob Heinsohn was very instrumental. He was my program officer for many years before he got promoted. And I'd also like to acknowledge Peter Wybrow for building the kind of department at UCLA where this kind of research is possible. So I'm going to go quickly through 20 years of research, and I hear 10 minutes, so we'll calculate how many years per minute. First of all, we did a randomized controlled trial of supported education, supported employment. We used the Dartmouth model, individual placement and support. I won't go into the details of this because of time. Some of you know it. But basically, it's a model that integrates what traditionally is the separate psychiatric service and Department of Vocational Rehabilitation Services, integrates them into one site, brings a job specialist, job coach, or in the case of first episode patients, also sort of a school coach into the clinic. Improves coordination because it's all in one facility. And the goal is directly returning people to competitive employment or regular work settings, continuing to support them there, not just placing them and helping them to get placement, but supporting them on the job, outreach to the community. This is the IPS worker, as we call it, the individual placement and support worker, is the only person in my clinic at UCLA that if I see her every day, I know there's trouble because she's not out in the community enough. It's when she's working in the community a lot that I know we're really adhering to the model. What happens when you do this? The control group here was standard Department of Vocational Rehabilitation care, which resulted in 40% of the first episode patients returning to regular school or competitive work in 6 months, but 83% of the people with this enhanced supported employment, supported education. If you looked at the next year after that, in which we continued this model at a step down level, we were able to keep 92% of the people who had supported education, supported employment, in their competitive work or regular school for at least part of that next year. The other group continued to improve. First episode patients really want to go back to work or school, but there's still a very significant advantage to this approach. So we were convinced that this worked. And in our subsequent research, instead of randomly assigning people to competitive, to supported employment, supported education, everyone got this form of treatment as a baseline. And we asked ourselves, what can we do to improve upon this? In that initial study also, we found that clearly there was, if you looked at the whole 18-month study, clearly there was an advantage to the enhanced supported employment group in terms of length of work or school. What then remains? First of all, if you look at the predictors of who returns to work or school and the quality of work or school functioning if you get them there, it's really the cognitive deficits at baseline when they first enter your clinic that determines how successful they are. It's the dominant factor in everyday functioning in schizophrenia in this early course. The other thing that happens is medication non-adherence. Patients in the early course of schizophrenia are young, they believe they're invulnerable, they don't believe oftentimes they have an illness, they don't understand why you keep insisting that they stay on their antipsychotic medication. Peter Wyden has summarized the literature as half the people go off their meds in the first year, 75% within 2 years, and about half of all the direct medical costs of psychiatric hospitalization are directly attributable to medication non-adherence. So we did a study, a year-long randomized trial, in which we we tried to deal with both of these issues, cognitive deficits and medication non-adherence in one trial. And we randomly assigned people to either long-acting injectable antipsychotic medication, which is rarely used in first episode schizophrenia. Everyone saves it until people have gone off their meds multiple times and then brings it up as the big gun. But we instead used it immediately after a first episode or standard oral antipsychotic. In our case, both of those were versions of risperidone, the same drug, so it would be a clean comparison. And we also randomly assigned people to either computerized cognitive remediation program, fairly broad spectrum one, to try to improve their cognition, or to a control group, healthy behavior training, which was relaxation training and nutrition and a little bit of physical exercise. So what happened? Strikingly, long-acting injectable medication in the first year after admission to our clinic reduced the relapse rate from 33% in a year to 5%. And the long-acting injectable medications were hardly ever refused, surprisingly to many clinicians. In addition, what we found was it not only affected psychotic symptoms, but staying on your antipsychotic consistently during that first year, within 6 months also was related to your cognitive recovery. So it's a broader effect than just psychotic symptoms. And on the psychosocial side, what we found is if you take into account, now remember everyone's on supported employment, supported education, and then you can take into account what's attributable cognitively to them staying on their meds. You take that out statistically. You find, even in addition to that, that computerized cognitive training significantly improves their cognition. So it can again boost their cognitive functioning above those other two things. And indeed, it helps their everyday life functioning. This is on a scale that Tara Neendam developed while she was still our student at UCLA. So here, their actual everyday school work functioning did improve with this combination. I didn't mention it, but a similar effect for long-acting injectable medication. So these look like, to us, proven successful treatments for first episode schizophrenia, important to implement in community clinics. Where are we now? The last thing I'll mention is more in the realm of this is what we're up to now, and we don't know for sure whether this will work, but it looks good so far. We're impressed that we still have a ways to go in terms of getting cognition back to really high levels in schizophrenia, even with these helpful treatments that I've mentioned. We're impressed with the literature on aerobic exercise, which has been shown in other populations to release neurotrophic factors, especially brain-derived neurotrophic factor called BDNF, a factor that in the brain expresses itself and is able to stimulate synaptic plasticity and enhance learning, especially in the hippocampus. And we're impressed that theoretically it should help stimulate learning in computerized cognitive training. It makes sense that you could combine these two and enhance the effect. We did a pilot study, and indeed on the first 14 subjects, which we've now just analyzed an independent 30 subjects and getting very similar results. Indeed, we do get enhancement of the effect of computerized cognitive training when you add regular 4 times a week, half-hour vigorous exercise periods. And this goes beyond sort of non-social, what we sometimes in the field call cold cognition, into social cognition. That is the kind of cognition we use as we interact with each other, understanding emotions, the thoughts of others, and how to effectively interact with them. So our early data suggested also enhances the generalization to real life functioning. So this also, although this one I won't stake my life on yet, we like to do another larger study, it looks good. So what are our overall conclusions? Supported education and employment. There's also a superb Australian study on this with first episode patients with very similar results. This looks solid. This looks like it can really improve the rate of people returning to work or school. Long-acting injectable antipsychotic, rarely used at the beginning of schizophrenia, looks to us to be a promising pharmacologic strategy. Systematic cognitive training, various computerized training regimens look like they can impact cognitive functioning and real-life world functioning. And for the future, we're hoping to show that aerobic exercise, wearing a Fitbit like I have on here and keeping track of your exercise every day might even help us beyond those traditional treatments. Thank you very much.
Let's start with the questions. Fortunately, so far, most of them have fallen into a few themes. So the first one we'll start with is to Dr. Loewy. There actually were 4 questions that ask different versions of the same thing. So I'll just read this one. Do you think, what do you think the reason is for the turnover in community-based organizations? Is it low wages and benefits? Are there other reasons for this? Are there things that we could do to improve it? And how overall does it impact the notion of being able to disseminate these new treatment models, which are a little richer and more complex than typically are implemented in the community in the real world? Is there a way to make things better?
Okay, so I don't know, is this working? Yeah?
Yep.
Yes, so we've thought about this quite a bit. The question of why the turnover and what do we do about it? So the turnover is obviously not specific to these kinds of programs. This is a big issue in all kinds of dissemination research around how do you implement and then maintain the fidelity of these kinds of models. I think one aspect is that it is a unique program, so I think Dr. Needham has some advice later about how to address this that we've talked about in terms of selecting the right people to be staffing these programs. They have to know what they're getting into. This is not the kind of program that's good if you have clinicians who are not ready for evidence-based practices, not interested in them. That would not be a good choice. So there are ways to assess that. Also, though, I think part of it is the workforce issues of a lot of these programs in various counties employ young staff who are trainees. They are not licensed. They get their hours for licensure and all of this training, and then they go off to be better paid at Kaiser. So, or wherever else. It's a whole, not specific to early psychosis. So one of the things I've been thinking about is how we as a state, given that there are all of these different programs, can develop some sort of upward mobility track. How do you hold on to the good staff that you have who are invested in this work and give them opportunities to move into leadership positions? If all you have are a single team, there's nowhere to go. But given that there is this huge network, how do we start? I think there's advantages for supporting each other in terms of the kinds of training I've been talking about and crossover when there's staffing differences, but then having, say, people who have a regional role or a statewide role so they can sort of move up a ladder in terms of their professional development. I think I've talked to folks in San Mateo County. I see some of them here, and that's been very successful, I think, for them. And how do they hold on to good county employees by creating more upward mobility for them within the system? So that's something of a solution.
Okay, no, that's great. Maybe any other comments from the panel or even from the audience about this issue? If not, I'll move on to a question for Dr. Marder. So, Steve, can you discuss the experience of the African-American musician within a cultural context? Was his reaction typical within this context?
It's a very good question. I mean, there is a literature suggesting that African-American men, when they're more often treated involuntarily, they're more often treated with higher doses of injectable medication, and that these kinds of treatments, which are highly aggressive, sort of stem from a kind of fear that treatment systems have, and again, apparently for this man, this treatment was so terrifying that it led to his refusing treatment, and he continues to refuse treatment. And one always wonders if he had had the kind of sympathetic care that other people have, whether or not that would have changed the whole course of his life. As many of you know who've seen the movie, the Soloist, or read the book, Nathaniel Ayres, despite being very talented, has spent much of his life homeless and really on the margins of society.
And I think one of the issues maybe that this can also raise is that identifying people at the very early phases of their illness and engaging them in treatment can reduce the trauma that's associated with mental illness at many levels. The trauma of being psychotic, the trauma of being hospitalized, the trauma of being treated involuntarily, etc. So I think, do you think maybe in a way what we're talking about is trauma here that there might be a broader cultural context for?
Right. No, I think his treatment was traumatic and makes sort of interactions with the with treatment providers frightening to him, and he's talked about that, and in the book it describes how attempts to treat him actually make him extraordinarily angry. So I think that context, and you could also wonder if there were people who tried to keep him in school, who educated him about the illness, whether or not that would have changed his attitudes towards treatment providers.
Dr. Loewy?
I absolutely agree that the collaborative care kind of model can have an effect here. I also just don't want to miss the aspect of that question that was really asking about different cultural issues and diversity issues. So that is definitely a big issue, moving from the university setting into communities that are quite diverse. And similarly, some of the challenges we faced where you need staff who are bilingual, bicultural, and you have to train them in evidence-based practices, and you have to meet the needs of very diverse communities for us in the Bay Area, where there are a number of different ways you want to approach different cultural understandings of what psychosis is. And I think that's a huge part of this kind of approach that's really important, is that there is this medical model meets recovery model place in the middle. So that we don't have to fight each other about it, but we can find some way to integrate.
And I would add, actually, that even based on our experience in EDAPT and PsychAdapt and the EDIP, Robert Johnson-funded EDIP project, that even the selection of the menu of evidence-based practices that you have available to you needs to be informed by the cultural makeup of the community that you're working with, because there's some big differences in terms of different kinds of interventions and their acceptability or non-acceptability simply based on culture. Absolutely. So here is a question for Dr. Cadenhead. It's one of those. So I think one of the interesting things that in this quick Cook's tour that we've done of different programs in California, we've looked in a way at the kind of range of contexts for trying to do this work. And we have this sort of artificial division, at least in the United States, between the public sector and the private sector. There are some real disparities that can present themselves that are a little bit of the converse of what you normally expect. If you're lucky enough to be in a county like Sacramento or maybe San Francisco or San Mateo, and you're a county consumer, you have access to kind of world-class evidence-based treatments for early psychosis. And if you have private insurance, good luck finding a psychiatrist, or good luck finding that multidisciplinary treatment team, except in places, we have it in Sacramento, you have it in San Diego, where you also kind of try to work with the private sector. And so this question is kind of related to that. How are we working as policymakers with insurance companies to facilitate inpatient hospital treatments? And this is a question for you, but it might be a question for some of those policymakers out there as well. And I would say not just inpatient, but outpatient, intensive outpatient care in general for this population, which is not going to do very well just going and seeing a psychiatrist and getting a prescription.
Well, it's a little bit hard for me to speak to the insurance industry because it's not something I've ever really invested much time in until recently as I've been learning about it. I had thought that with some of the parity laws that the insurance companies would be required to provide the same level of care that you do for physical illness. And it turns out, I don't know that that's being enforced, really. And so there are some insurance companies that provide pretty decent coverage. Others, I'm sure everybody here has had to deal with these kinds of things, even for your own health, where you have to really fight to get the care that you need. You know, it's so ironic. We work with TRICARE, which is the military insurance, and for example, they won't support an intensive outpatient program, which is a step down from day treatment. They will only support day treatment. So they refuse to fund for an intensive outpatient program. You know, there are all of these, and I think that intensive outpatient programs in general are receiving better support from insurance companies. But I would love to see universal health. How much easier would that be if you only had to go to one entity to get your approval? Okay. Yeah. But other people may have more experience with this. I'd love to hear thoughts on what can be done to get the insurance industry on board.
Is Daryl here? He and I wrote an op-ed on this a couple of months ago for the Sacramento Bee. I guess he's not here. Garen Staglin, would you like to add something? We can get you a microphone.
Well, just to say that the parity law was passed, co-sponsored by Patrick Kennedy, who's our co-chair with us in One Mind, and Patrick is working actively. The issue is they have not finalized the rules and regs for the implementation of the parity law, and the insurance companies are using that lack of clarity to delay and deny and to muddle the process. And so we're trying to turn up both the political heat and the availability of evidence-based treatments that would allow us to be even more forceful and make such treatments covered by it. I mean, just the very fact that the only coverage is in for RAISE programs. You can get coverage right under the Affordable Care Act for treatment under RAISE, but you can't get it under NAPLES. It's not available for early intervention work. Is a clear mismatch in what we're all trying to accomplish. So there's more on this that we can make available, but it's too long for right now.
Yeah. So it's an excellent question for which the answer is highly complex. More needs to be done. So another high-level question here. I think for the panel, but I think also anyone here. How would we implement EpiCal? Who would do that? How would it be supported? And then there's some questions about where does the money go that's distributed through Prop 63, which I think lots of people here actually know the answer to. But I think that's a good question. I think EpiCal is an awesome idea. We have these UC-based programs. We have these UC-based programs that are at the leading edge and have been for a long time. And we've seen the bleed out that Bob has talked about, where we've engaged providers in our communities, we've done trainings, we've partnered in different ways, and we're beginning to disseminate across the state. If we all got together and compared notes and worked together, the sum would be very much greater than the parts. But the challenge, and actually now to think about it, now we've got someone here from the NIMH. Perhaps Dr. Heinzen might comment on his ideas about how practically you'd make that happen. And I think maybe how we could have partnerships between all the various groups that are invested in this. We already have a partnership between SAMHSA and the NIMH, and that's had an impact already in terms of the development of EpiNet and the block grant set-asides and all of that. Could there be partnerships at other levels that you could imagine, Bob?
Well, the first question about who's going to build this and how would it be sustained over time? For EpiNet, it's unknown. Well, it's unknown. Actually, it is known who will build it. NIMH is going to start building it, and how it will be sustained over time, I don't know yet. But that's not a reason not to start, I don't think. So I believe that, so my feeling is with EpiNet, if we begin to build it and we show that it has value, people will want it, and somebody smarter than I will figure out a way that will make this a going concern, a business opportunity, or some way it will have enough value that it will draw resources that will sustain it. But as I said, not knowing exactly how that's going to work is not a reason not to start demonstrating that it can have the value. So I don't know enough about. Well, clearly I don't know enough about the federal the federal scene to give you a clearer answer. So I'm not going to even attempt to say how you would do EpiCal, other than to reiterate what I said before. Is I think, EpiNet will be built on the basis of local contributions and local stakeholder involvement, and in that sense, the different groups will aggregate up from the local level, So it may be something that we develop this together. As we're developing EpiNet, we want you there to say, well, what do we need in California? How would this thing be useful to us? And how would we clone, some of this or co-opt some of this for our own purposes? The same way that I would hope that, Rhode Island and Connecticut and Montana will do the same thing with this, is that how can we all capitalize from this very large resource that then can be used to inform our decisions about our local concerns.
And I would add that we're going to hear from Daryl. He'll have some ideas about this. We're going to hear from Toby Ewing a little later in the day. And the behavioural health centres are very much invested in contributing in some way to this process as well. One last question for you, Bob.
Could I add one thing to that
sure,
one?
absolutely.
Sorry, while we're talking about it, I think there's a couple of pieces. We've talked a bit about all of the programs that were developed in partnership with these NIH-funded UC sources, but I also want to note and give credit to the number of counties in California who also have programs of their own that they've developed in partnership outside of working with us. And there are, I'm not sure exactly how many, someone can let me know, but at least probably there are 4, 5, 6. There's 24 total. Is that it? Yeah. So a dozen that are outside of what we're doing. And so that's where I think we start, is to look at what we can do to work together across all of those. And I know a challenge for the MHSA OAC has been, how do you evaluate these 24 programs? And there have been various attempts to do that. So I think it is a potential solution, actually, to that issue, to say, well, how do we make sure we are collecting some of the same information across all of these programs, and how do we start to pull that together to answer questions about how, what is most effective within California? So I think sort of a win-win there, but I'll let someone from the MHSA talk about that.
So one last quick question before we take our quick break, and it's for Dr. Heinzen again, and I think the answer is short. Will there be, or is there, a process for early psychosis intervention programs to join the EpiNet?
It's actively in development. This next year, there'll be a series of meetings, engagement activities. We would like to follow some of the work that the Precision Medicine Initiative has pioneered in terms of active engagement, transparent decision making, and along with a rapid development of planning and rollout. So within this next year, you will be hearing in a regular basis about this, and we will be reaching out to people who are interested partners. And we want many, many partners, not just researchers, not just clinicians. We want family members. We want service users. We want it to be a very inclusive process, so a product that meets the needs of multiple stakeholders.